Hello everyone, welcome back to this short tutorial from Pathology Made Simple at ilovepathology.com. This is the part 4 of diseases of immune system, and in this part we will begin with hypersensitivity reactions, and today we will discuss type 1 hypersensitivity reaction. So in the next few minutes we will see what hypersensitivity reaction is. We will understand some general principles of hypersensitivity reaction. We will look into what are the different types of hypersensitivity reactions and then in detail about type 1 hypersensitivity reaction. So what are hypersensitivity reactions? These are the immune reactions which are injurious to the body. So in the context of hypersensitivity reaction, we should understand what is sensitization or who is a sensitized individual. So a sensitized individual is one who has been previously exposed to antigen, right? Now, if this individual, upon re-exposure to that particular antigen, he or she will develop detectable reaction. And remember, this reaction is excessive. This reaction is harmful, and that is why it is referred to as hypersensitivity reactions. So let's move on to understand the general features of hypersensitivity reaction. Firstly, these reactions can be elicited either by exogenous antigens or by endogenous antigens. When I say exogenous, it means environmental antigens, and endogenous meaning self antigens. The important exogenous antigens which are environmental are microbial antigens and non-microbial antigen. Microbial, of course, all the microbes you know can be an exogenous environmental antigen, whereas non-microbial antigens include dust, pollen, food, drugs, and various chemicals. So the symptoms in this particular case will be as minimal as just itching, could be as fatal as anaphylactic reaction. The general terminology we use for this hypersensitivity reaction due to exogenous antigen is called allergy. Whereas the terminology we use for hypersensitivity reaction to self antigens is referred to as autoimmune diseases. We will talk about autoimmune diseases in more detail in subsequent sessions. The second important thing you need to know is that when there is a disorder in this balance, when the effector mechanisms are too much, or when the control mechanisms have come down, that is when the reactions will be hyper. That's why they are hypersensitive reactions. Next important thing you should understand is that not everybody, okay, will develop hypersensitivity reactions. So it is always or often associated with inheritance of susceptibility genes. Okay, and these genes either could be HLA associated genes or non-HLA genes. So we will understand these susceptible genes when I talk about different types of hypersensitivity reaction. Now, the reactions or the immunological injury or the tissue injury, it is not different from the regular effector mechanism. Okay, so the mechanism of tissue injury is just similar to that of normal effector mechanism, but it is poorly controlled. It's excessive, and that's why I call it as hypersensitivity, and it can also be misdirected. Okay, the reaction or the hypersensitivity reaction can be even against the normal harmless environmental and self antigens. So how do you classify hypersensitivity reactions? They are broadly categorized into four: type 1, type 2, type 3, and type 4. Type 1 is immediate hypersensitivity reaction, the examples being anaphylaxis, simple allergies, bronchial asthma, etc. Type 2 is referred to as antibody mediated hypersensitivity reaction. The various examples include autoimmune hemolytic anemia, Good-Pasteur syndrome, and so on. Type 3 is immune complex mediated. Remember, type 2 is antibody mediated, whereas type 3 is immune complex mediated. The common examples being systemic lupus erythematosus, serum sickness, and Arthur's reaction. Type 4 hypersensitivity is cell mediated. Okay, so they are cell mediated. The examples being tuberculosis, multiple sclerosis, type 1 diabetes, and sometimes contact dermatitis. So now let's move on to understand type 1 hypersensitivity reaction. Now, what is this? This is a rapid immunologic reaction. Okay. So this is a rapid immunologic reaction occurring in a previously sensitized individual. Okay. Now, why this immunological reaction occurs? How it is triggered? It is triggered by binding of an antigen or an allergen to IgE antibody on the surface of the mast cells. Right? The effector cell in this hypersensitivity, that is immediate hypersensitivity or type 1 hypersensitivity, is the mast cell. So this is often called as allergy, as we studied earlier, and the antigens which are implicated are known as allergens. Right? So they occur in two phases. I mean, the type 1 hypersensitivity reaction occurs in two phases. One is immediate reaction, and second one is late phase reaction. Immediate reaction meaning the reaction which occurs within minutes after exposure to an allergen, and it tends to subside in few hours, whereas late reaction is the one which begins at around 2 to 24 hours and then it stays for longer duration. What are the manifestations of immediate reaction? It can be vasodilatation, vascular leakage, smooth muscle spasm, or sometimes glandular secretion. If you are looking at glands being involved, mucosal glands being involved, for example. Whereas late reaction is infiltration of the tissues by the leukocytes. What are they? They can be eosinophils predominant. The most common cells are eosinophils. They can be eosinophils, neutrophils, basophils, monocytes, and CD4 positive T cells, leading on to tissue destruction or mucosal damage in the long run. Okay, so that is a late phase reaction. What is the basic mechanism of type 1 hypersensitivity reaction? In this case, there is excessive T helper cell response. Let's understand in detail about how this excessive T helper cell response results in type 1 hypersensitivity reaction. So consider this as a mucosal surface, say a bronchial epithelium. So that's a respiratory epithelium. Now these are columnar epithelial cells with the cilia, and that is the mucus. Imagine you get exposed to an antigen or an allergen. Okay, what happens? This allergen gets inside the tissue and then it is recognized by the dendritic cell. Okay, the peptide of this particular antigen is expressed on molecule. Okay, this is an MHC molecule on the dendritic cell. So this dendritic cell presents the antigen to the naive T cell. So this naive T cell gets converted to T helper cell. Okay, with the expression of many of these molecules. Other important factor which helps in the conversion of naive T cell into T helper cell is by this interleukin, by this cytokine interleukin 4. Now you have this T helper cell which can recognize these antigens, right? So once they recognize these antigens, they secrete or they release interleukin 4, interleukin 5, and interleukin 18. So let us see what these do. Interleukin 4, it stimulates the B cell. So what happens now is that this B cell, normally, B cells secrete immunoglobulin IgM, immunoglobulin M. But then in these cases, there is a class switch, which means instead of producing immunoglobulin M, these start producing immunoglobulin E. This is what is referred to as class switch to IgE by these B cells. So this interleukin 4, as we saw earlier, it also helps in conversion of naive T cell to T helper cell, right? At this point, remember that you have a B cell which has changed itself in the sense now it starts producing IgE antibodies. Now, what is the role of interleukin 13? It enhances IgE production by these cells. And interleukin 5 is the most important one, which is the one which results in activation of eosinophils. So before I forget, you have interleukin 13, which also stimulates mucus production by these epithelial cells, and that's why you have lots of mucin in these cases. So remember, the T helper cells secretes or releases interleukin 4, interleukin 13, and interleukin 5. So interleukin 4 not only activates the naive T cells to get itself converted to a T helper cell, it also activates the B cells where it gets converted to a cell which can produce more IgE antibodies. And then you have interleukin 13, which enhances IgE production as well as stimulate mucus production. And lastly, you have interleukin 5, which activates the eosinophils. So this B cells mature to form into a plasma cell, which starts secreting lots and lots of these IgE antibodies. So now in this individual, you have lots of IgE antibodies. And remember, in the same tissue, you also have mast cells. Now, what are these mast cells? These are actually cells which are derived from the bone marrow, but then they are widely distributed in the tissues. They're usually abundant near the small blood vessels and nerves in the subepithelial tissue. And that's why, these are the most important cells in these hypersensitivity reaction. Now, what happens to these mast cells is that they express receptor which can identify these IgE molecules. Okay, you have an FC receptor which identifies the IgE molecule. Now, this particular phase, when you have mast cells with IgE antibodies attached to FC receptor, this phase is referred to as the person is a sensitized individual. Now, if this individual, upon re-exposure, imagine you have an re-exposure to the same antigen, this person need not have to go through all these steps. Okay, the mast cells are directly activated. Now, only important thing you need to know about the mast cell activation is that for it to be effectively active, this antigen has to bind at least two adjacent IgE molecules. So when it binds to adjacent IgE molecules, the mast cell is active now and then it degranulates, okay, releasing all the mediators which is there inside the mast cells. So what do these mediators do? They are the ones which mediate type 1 hypersensitivity reactions. So what are the contents, or what are the components of mast cells which participate in type 1 hypersensitivity reaction? The first one is the granule content. The second one is the lipid mediators from the mast cells, that is particularly from the plasma membrane. The third one is the cytokines which are produced by these mast cells. Now, what are these granule content? So the granule content can be vasoactive amines, it can be enzymes, or it can be proteoglycans. What are those vasoactive enzymes? Histamine is the most common vasoactive amine. It is the one which results in smooth muscle contraction. It increases vascular permeability and it also stimulates mucus secretion. What are the enzymes? The enzymes are chymase and tryptase. What do? They cause tissue damage and it also helps in generation of kinins. What are the proteoglycans? These are heparin and chondroitin sulfate. They are the ones which result in they are the ones which actually package and store the amines, histamines. They are the ones which actually store these amines in the granules. Now, what are these lipid mediators? Lipid mediators are actually the arachidonic acid mediators from the plasma membrane, and also it includes platelet activating factor. The role of platelet activating factor in immediate hypersensitivity reaction is not much, so we will not discuss about that. Now, what about the arachidonic acid derived products? They can be leukotrienes and prostaglandin D2. Leukotrienes are B4, C4, and D4. B4 is the chemotactic for eosinophils, neutrophils, and monocytes, whereas C4 and D4 are the ones which are vasoactive and also spasmogenic. See, the prostaglandin D2 is the one which results in bronchospasm and also increases mucus secretion. Now, what is the role of cytokines? What are all the cytokines which are produced by the mast cells? They include tumor necrosis factor, interleukin 1, and other chemokines, and also the most important interleukin 4. So these chemokines, interleukin 1 and TNF, are the ones which are majorly responsible for leukocyte recruitment. Okay, and eosinophils is the most common leukocyte which is recruited. Whereas interleukin 4, as we all know by now, that it amplifies the T helper cell response. So this phase where you have, the immediate phase manifestations is brought about by the granule contents and the lipid mediators, whereas the late phase manifestation is brought about by the leukocyte recruitment. And this leukocyte recruitment is the one which amplify and sustain the inflammatory response. And this is what is called as late phase manifestation. And remember, this late phase manifestation occurs without additional exposure to the triggering antigen. You don't need antigen for that. It is just that the chemokines start recruiting more and more leukocytes, particularly eosinophils, and then the eosinophils is the one which causes major damage along with other leukocytes. So let's understand the late phase manifestations. It is said that the late phase manifestations is the major cause of symptoms in type 1 hypersensitivity. And then, as I told you, eosinophils are the most abundant leukocyte population. So how do these eosinophils are attracted towards the site of hypersensitivity reaction? It's by the epithelial cells, T helper cells, and mast cells, which releases chemokines, particularly the eotaxin and interleukin 5. Eotaxin is by the epithelial cells, interleukin 5 is by the T helper cell as well as mast cells, which recruit eosinophils. And these eosinophils have proteolytic enzymes. They have unique proteins and they also have crystals. See, the proteolytic enzymes and the unique proteins, particularly the major basic protein as well as eosinophil cationic protein, are the ones which result in tissue damage. So, the tissue damage by the eosinophils is brought about by the enzymes and these unique proteins. Whereas crystals, particularly the charcot-laden crystals, which are the ones which contain protein called galactine 10, they are the ones which promote inflammation and it also enhances T helper cell response. I told you now, the major cause of type 1 hypersensitivity reaction is enhanced or increased T helper cell response. Now, the next question is, does everyone exposed to allergens develop allergy? Absolutely no, because susceptibility to immediate hypersensitivity reactions is genetically determined. Okay, now what are the genes responsible for that? There can be polymorphisms in several genes which encodes cytokines, particularly interleukin 3, 4, 5, 9, 13, and GMCSF, granulocyte monocyte colony stimulating factor. So these are non-HLA genes, or they can be polymorphisms in some HLA genes as well. So the propensity to develop type 1 hypersensitivity reaction is referred to as atopy, right? Now, if you examine the blood in these individuals, it is found that these individuals have very high serum immunoglobulin E levels and they also have more and more interleukin 4 producing T helper 2 cells. Apart from genetic factors, there are various environmental factors which results in type 1 hypersensitivity reaction. It is said that around 20 to 30% of immediate hypersensitivity reactions or type 1 hypersensitivity reactions are triggered by non-antigenic stimuli. You don't need antigens. It's by non-antigenic stimuli like temperature extremes and exercise, and they do not involve T helper cells or even immunoglobulin E. And this is called as non-atopic allergy. What is the mechanism in non-atopic allergy individuals? It is said that in these individuals, the mast cells, they are very, very abnormally sensitive to activation by these stimuli, and they immediately degranulate and then release all the mediators and then all the manifestations of type 1 hypersensitivity reaction. The incidence of type 1 hypersensitivity reaction is increased in high income countries, particularly populations who have urbanized and exposure to natural environment has diminished. Those countries, they have a very high incidence of type 1 hypersensitivity reaction, and that is where this hygiene hypothesis has come to play. Because of improved hygiene in urbanized, and high income countries, they are not exposed to allergens, and that's why improved hygiene in early childhood may increase allergies later in their life. Of course, this has to be proved beyond doubt. It is very difficult to prove this hypothesis. Let us understand the various examples of type 1 hypersensitivity. It can be broadly categorized into systemic, which is referred to as anaphylaxis, and local. Systemic anaphylaxis can be either in the hospital setting or it can be in the community setting. Hospital setting, the examples being, administration of foreign proteins. For example, administration of antisera, where the patient develop immediate reaction. Administration of hormones, administration of enzymes, polysaccharides, drugs. That is why they give a test dose before administering all these material. The examples of community setting includes a food allergen or insect toxin. Food allergen, the most common food implicated in hypersensitivity reaction is peanuts and shellfish. The toxin, very, very common example being bee venom, right? Whereas local hypersensitivity reaction can be by pollen, animal dander, house dust, or even various kinds of food. The manifestations could be urticaria. It can be simple itching. It can be allergic rhinitis. That's what we refer to as hay fever. It can be, even in the form of bronchial asthma, could be skin manifestations like atopic dermatitis and various food allergies. Let us see the clinical features of systemic anaphylaxis. Usually, as soon as the patient is exposed to these agents, right, it begins with itching, hives, and skin erythema immediately within minutes after exposure to allergen, and then moves on to having manifestations of respiratory distress. That's because of contraction of pulmonary bronchioles. Okay, laryngeal edema can be a feature which can result in hoarseness of voice, and then the patient will have vomiting, abdominal cramps, diarrhea, and severe laryngeal obstruction, which can lead to respiratory distress, shock, and death within an hour if it is not treated immediately. So, how do you manage? If you have a choice, it's always good to avoid these allergens, but then sometimes it is not possible. If you identify that there is hypersensitivity reaction, the best thing is to give antihistamines or corticosteroids to relieve these symptoms. And if it is very, very severe, emergency administration of even epinephrine may be necessary. So that's all about the type 1 hypersensitivity reaction. We talked about the general principles and in detail about the type 1 hypersensitivity reaction. Thank you for watching. Do comment if you have any queries to ask. If you feel this content is useful, do consider subscribing this channel, and also please share if you find this content useful so that your friends or somebody else might be benefited from this. Thank you.